Hi, I'm Helen Gauci, and I will be taking you through the DNA Mind webinar, Genetics of Mental Health by DNA Life. So starting off, what is the DNA Mind test? This is a new test that we recently launched that analyzes 37 genetic variations in 29 genes involved in key biological processes associated with mental health. In these areas, we look at neurodegenerative disorders, including your LODE or late onset Alzheimer's disease, your dementia and cognitive decline as well. In mood regulation, we look at variations associated with bipolar as well as depressive disorder, anxiety disorder, and your PTSD, which is your post-traumatic stress disorders. And then also what we consider are variations in addictive behavior, from risk for alcoholism and nicotine and cannabis dependence to opioid dependence and other substance abuse, as well as psychosis response from cannabis use, and then considering your binge eating disorders and other addictive behaviors, from compulsive behaviors to adrenaline seeking, risk-taking behavior, and compulsive gambling. In the neurodegenerative section, we consider variations in ApoE and lipid metabolism, a number of SNPs in genes in your inflammatory pathway. BDNF is tested in your neurotrophic pathway, and COMT is tested in your dopaminergic pathway, and these SNPs have all been related to neurodegenerative disorders. In your mood regulation, we're looking at key pathways from methylation to want signaling and inflammation, as well as your serotonergic pathway and again your neurotrophic pathway coming up. We also again consider COMT variation in your dopaminergic pathway and how that is related to mood regulation. We also look at a very exciting area assessing variations related to stress response, and here we're looking at FKBP5 and OXTR, and then in your cell signaling, your calcium and sodium channels, CACNA1C as well as ANK3. And then lastly, in your addictive behavior section, we report on variations in AKT1, CHRNA3 and 5, which has got to do with cell signaling. In your GABAergic pathway, we look at your GABA2, which is your GABA receptor. The serotonergic pathway, we are testing for SLC6A4 variation. And again, BDNF is reported on in your addictive behavior section. Following on in addictive behavior, we include a number of SNPs in your dopaminergic receptor genes, from DRD1 to DRD4, as well as COMT coming up again, and then also looking at a key variation in your OPRM1 gene. We also look at your CNR1 and FAAH genes, which are involved in your endocannabinoid pathways. Starting off, we're going to cover neurodegenerative disorder area first, and here we're going to just look at mild cognitive impairment and cognitive decline. What is it? And what we are actually reporting on is that mild cognitive impairment causes a slight but noticeable and measurable decline in cognitive abilities, including memory and thinking skills, and individuals with mild cognitive impairment are at increased risk of developing Alzheimer's disease as well as other dementias. And so it's very important to understand if there are variations associated with mild cognitive impairment, can we step in early enough to start managing and intervening to decrease the risk of that cognitive impairment going any further. Then when we get to our late onset Alzheimer's disease, we're looking at this as a complex and heterogeneous neurodegenerative disorder characterized by the gradual onset of dementia. This is where we have an impairment of memory, judgment, attention span, and problem-solving skills, and that is followed by severe apraxia, which is a disorder caused by damage to the brain. There's also a global loss of your cognitive abilities. The condition primarily occurs after the age of 60 in your late onset Alzheimer's disease individuals, and this is marked pathologically by severe cortical atrophy and the triad of your senile plaques, neurofibrillary tangles, and as well as including your neural threads. Moving on, we look at and then just looking at genetics of late onset Alzheimer's disease, it's important to understand that this is a multifactorial polygenic disorder. So several genes have been described as possible risk factors for development of LOAD, but environmental factors are also involved in the disease's progression. So the variations that we're actually assessing are not sufficient on their own to cause disease, and we do actually need to see environmental triggers that will lead to the disease progression. So there was a lovely article that actually reviewed a number of other variations that have been associated with LOAD, and this is a question that does come up: why are we only testing in this big area in terms of the other genes related to neurodegenerative disorders and especially Alzheimer's disease? Why do we only consider ApoE still? And the reason for that is because of our strict SNP selection criteria. From this review paper and many more, where we assessed a number of genetic variations that have been associated with LOAD, we need to consider the physiological understanding of the gene, and has that actually been established as of yet? And if not, we're not going to include it. The other considerations are also, what can we do about that variation? Again, DNA Life is very much focused on interventions, and if those interventions have not been established for the genetic variation, we again are more hesitant to include the variation. And lastly, we also want to consider variations that are relatively frequent in a population, and your ApoE4 variation, which is the risk for Alzheimer's disease, has actually been proven to be quite frequent in the population. Whereas something like TREM2, where we do actually understand the physiology behind it, we understand that there are interventions that we can put into place, the variation, however, is very, very rare in the general population, and so it would be unlikely that we would actually see that variation come up. So some of these candidate genes that we did consider from these review studies included your clusterin, CR1, the complement receptor 1, as well as PICLM, TREM2, and CD33, which come up a lot in different studies. However, ApoE is the strongest genetic risk factor for LOAD, it still is, and its importance has been validated from population studies, where the E4 allele is highly associated with mild cognitive impairment, your MCI, as well as an increased risk for Alzheimer's disease, the late onset. In mild cognitive impairment and cognitive decline, we also consider our inflammatory genes, IL-1 encoding interleukin-1, IL-6 encoding interleukin-6, TNF-alpha encoding your tumor necrosis factor alpha, and then CRP encoding C-reactive protein. And then it's a very interesting combination that we see in certain studies where we are considering a variation in your brain-derived neurotrophic factor encoded by BDNF and catechol-O-methyltransferase in your dopaminergic pathway encoded by COMT. And the combination of the risk variations with neurotrophic and dopaminergic pathways, BDNF and COMT, has also seen an increased risk for this MCI, or mild cognitive impairment, and together with ApoE, it is this compounding genetic risk and this genetic risk score that we can consider when looking at overall risk for neurodegenerative, especially the cognitive impairment diseases. So this is what you would see in your neurodegenerative disorders section, where we are considering ApoE, your inflammatory SNPs, COMT and BDNF, And there is a summary table in the front of your report where you would either see an N, an M, or an A, and your N is the key for neurodegenerative disorders. And so whenever you're seeing an impact factor coming up with the variant with the N, that is where it has been related, or there's research associated with an increased risk for your neurodegenerative disorders. So starting off with inflammation and neuroinflammation, this has been implicated as one of the potential mechanisms mediating the onset of a broad range of psychiatric disorders, including risk for cognitive decline and your load, as well as depressive disorders. So we actually report on it as the risk for both areas of mental health. And we can see that with an upset in the inflammatory pathways and an increased expression of these genes leading to increased levels of your pro-inflammatory cytokines, we actually see an imbalance of your M1 to M2 like phenotype, and we see that this eventually may lead to neuronal loss, astrogliosis, as well as your cognitive decline. So with your M1 and your M2, just to clarify that, your M1, like microglia, is your pro-inflammatory side, and this is significantly increased with neuroinflammation. And with M2, your anti-inflammatory, that can be decreased, it depending on whether you have the increased inflammation or not. So in the inflammation side that we're considering, we're looking at SNPs in IL-1 alpha and IL-1 beta, as well as your IL-1 receptor antagonist, IL-6 encoding interleukin-6, your TNF alpha, as well as CRP. And these are all polymorphisms of your pro-inflammatory cytokines that have been associated in the literature with cognitive decline. And so when we're seeing these variations come up, we know that it is very important intervention-wise to limit all pro-inflammatory triggers and then to emphasize all anti-inflammatory environmental factors, and really to put a strong emphasis on the strategy around anti-inflammatory interventions. And so to name just the pro-inflammatory side, we're looking at being overweight or obese, looking at aspects of the modern Western diet, a refined carbohydrate intake, high trans and saturated fat intake, as well as a low vegetable and fruit consumption. When there is a high or abnormal ratio of omega-3 to 6 fatty acids, sedentary lifestyle, infections, and then also considering, very importantly here, physical and mental trauma, as well as psychosocial stress. And there's a lot of research actually showing that psychosocial stress, and even if it's not a physical, but if it's a mental trauma, can actually increase expression of these pro-inflammatory cytokines. And if at baseline, because of genetic variation, you are more at risk for increased expression, this becomes a very important area to focus on. And so in terms of the anti-inflammatory interventions, the indirect anti-inflammatory interventions would be to consider the Mediterranean-style diet and components thereof, as well as put in regular, moderate intensity exercise. And then from the nutrition side, that directly decreases the expression of these pro-inflammatory genes, we look at our omega-3 fatty acids, curcumin or turmeric, as well as resveratrol and your other anthocyanins from your red and blueberry family, as well as just your overall black and red berry family and fruits and vegetables. And then also very important to manage stress in the environment and consider those psychosocial triggers and how can we better manage that. Moving on then to your BDNF, which encodes brain-derived neurotrophic factor. This is the most widely distributed neurotrophin in the central nervous system, where it plays several pivotal roles in synaptic plasticity and neuronal survival. Research reports an altered levels of BDNF in the circulation, where serum or plasma of patients with mild cognitive impairment and Alzheimer's disease, as well as depressive disorders, have lower levels of BDNF. And so low levels in your CSF may be a predictor of future cognitive decline in healthy older subjects. So it's a very interesting one. If you can get that tested, it would be very useful to be considered as a predictor. And higher levels of expression may decrease risk. So decreased BDNF serum levels also correspond to the severity of cognitive impairment. So very, very important gene to look at. The variation is a C to a T change, so the T being the risk, or it actually, we look at it in the literature as an amino acid change from a valine to a methionine. The presence of the methionine allele, being the T, results in a 25% reduction in activity-dependent secretion of BDNF in your central nervous system. The T allele carriers have shown a significantly faster rate of decline for measures of cognitive decline in studies where verbal and visual, episodic memory, and language are quite strongly affected. And this is also associated with increased risk for depression and addictive behavior disorders, including binge eating. The SNP exerts these effects by impacting intracellular trafficking and activity-dependent secretion of BDNF. Advanced age and low educational level are also environmental factors associated with decreased BDNF serum levels. The biggest intervention to improve BDNF and actually trigger expression, so this would be your nutrigenomic intervention, but actually the variation, the T allele variation gets the best response, is where we see physical activity, and increased physical activity has a positive association on BDNF levels. And recent studies have actually shown that high intensity interval training has the best change in BDNF levels, especially in T allele carriers. Considering this in terms of binge eating, extreme calorie restriction or strict diets increases binge eating behavior in BDNF T allele carriers, and that's just in the addictive behavior to remember. Then something that's always compounded and actually researched a lot with BDNF is COMT. And here we're looking at the COMT gene that we test in our DNA estrogen, as well as in our DNA health tests, and also considered in our MedCheck test. COMT encodes the catechol-O-methyltransferase enzyme and is responsible for the methylation of your catecholamines, thereby regulating dopamine levels primarily in the prefrontal cortex. This is an amino acid change from a valine to a methionine, which affects human prefrontal cortical function, and as such is strongly associated with differences in neuronal processes underlying cognitive output. Because of the lower enzymatic activity with the A allele, or the MET, the COMT polymorphism results in greater dopamine levels for COMT MET-MET homozygotes compared to VUL allele homozygotes. Carriers of the VUL allele, however, may thus be at higher risk for brain and cognitive deficits, including executive functioning. So just to go over this again, we see that with the variation, you get a change in the actual activity of the enzyme. So with the GG, or the VUL genotype, we have higher COMT activity. With the AG, VUL-MET genotype, it's moderate COMT activity, and with the MET-MET AA genotype, we have lower COMT activity, significantly lower. So in terms of its function and breaking down these catecholamines and breaking down dopamine, and considering that dopamine is important in neurodegenerative health. We actually want to have a slower enzyme that doesn't break down dopamine that quickly. And so with GG or VUL genotype carriers for COMT, this is the genotype that is associated with cognitive deficits and lower executive functioning. Combining this with the risk BDNF variant is where the interaction becomes very strong. But what they have actually found in terms of intervention, remember intervention being so important, is that higher lifestyle activities may protect those with the risk from cognitive decline. So in terms of these lifestyle items, these include being social, visiting friends, getting out and being physical and active, even things like gardening has been shown to be very important. Also including integrative information processing, such as playing a musical instrument or doing something outside of your typical routine and day-to-day job. And then doing novel information processing, such as completing jigsaw puzzles, word puzzles, and number puzzles. And so these would be the interventions that one would look at if you see a GG genotype, and especially if you see GG genotype for COMT plus TT genotype for BDNF. And then lastly, we look at ApoE very quickly. This is again just an overview where ApoE is the major cholesterol carrier in the brain and is involved in neuronal maintenance and repair. There are 3 isoforms that can be carried on this gene, so 2 SNPs that are assessed make up 3 different isoforms, the E2, the E3, or the E4. And you would carry 2 isoforms, one from each parent. So carriers of the E4 allele could increase the aggregation and deposition of amyloid beta protein in the brain compared to other polymorphisms. They have been associated with higher Tau levels, lower CSF amyloid beta levels, and greater brain atrophy with E4 allele carriers compared to non-carriers. So evidence suggests the risk in E4 carriers may be modified by regular moderate intensity exercise, following a low saturated fat and also a lower total fat diet, focusing on your anti-inflammatory diet, rich in omega-3 fatty acids, specifically your DHA, because with E4 carriers, there does seem to be a problem metabolizing your fatty acids and getting that DHA to your cell membranes. And as we know, DHA is so important in the plasticity of your neurons. So really focusing on a higher quantity of DHA. Also, it is important to increase intake of antioxidants and phytonutrient-rich foods. And then the avoidance of your pro-inflammatory triggers and pro-oxidants, including cigarette smoking, alcohol, and being overweight or obese, are very important factors to eliminate as environmental factors for E4 carriers. Moving on then to mood regulation, this is what the next part would look like. So we're looking at some of the N, as I said, for neurodegenerative. And then when you're seeing your M icon, and you're seeing variations related to the M icon, this is when it's been related to your mood regulation. So again, looking at your inflammatory SNPs, and then also considering methylation being very important in mood regulation. We know this. Looking at GSK3 beta, 3 SNPs involved in encoding on your GSK3 beta gene, encoding for either a normal or a higher expression of this and higher activity of this kinase in the 1 signaling pathway. With FKBP5 and OXTR, this is related to stress response. ANK3 and CACNA1 in your cell signaling. COMT and BDNF tested again, and then just fitting in at the bottom of the page in your serotonergic pathway is your serotonin receptor, your HTR1A, which is important in mood regulation as well. So a lovely study. It's unfortunately not open access, but if you can access it, it's now getting a little bit old, 2014, and there has something there has actually been another review study that's come out recently, but this pathway is just so nice to look at, where by Gatt et al., where they did a really nice review and analysis of genes and then variations related to different areas of mood regulation. And what I really want to highlight from this slide is how you can see how much these variations overlap with different conditions, different diagnoses. And so we also, what's very nice from this slide is you can see in the outskirts, the dark purple are where we're seeing genes that we're definitely keeping an eye on. These have been looked at in your genome-wide association studies and are coming up quite frequently, but we're just trying to determine the variations on these genes that really are going to make an impactful difference. And we want to see the frequency, the physiological function, and the intervention. But then as we go in closer and as these pathways and the genes become more clear on this image, that is where you are able to see the genes and the variations that have actually been tested in the literature and reported in the literature to have strong associations, and also both looking at responsiveness to medications, as well as we can start seeing how they would function in a biological pathway, and how can we offset those weaknesses by balancing that biological pathway with environmental interventions, including both psychosocial and nutrition interventions. Again, it's not everything, but it can definitely help to balance these pathways. And again, the variations on their own are not enough to cause disease. We do need the environmental risk variation, the risk factors such as psychosocial stresses, high inflammatory environments, a number of stresses from the environment to actually manifest and get these genes expressing in the wrong way. So here you can actually just see in some of them that we are testing for is your BDNF, MTHFR, ApoE, COMT, your dopamine receptors, HTTLPR, that's one of the serotonin ones we're looking at. So a number of SNPs in these pathways that we are considering. Okay, so what were we looking at in mood regulation? We're looking at a number of disorders from that slide. You can see there was quite a lot of overlap. From bipolar disorder, a major affective disorder marked by severe mood swings, both manic or major depressive episodes, and a tendency to remission and recurrence. We also look at depression and depressive disorder, which is a mental condition marked by ongoing feelings of sadness, despair, loss of energy, and difficulty dealing with normal everyday life. Other symptoms of depression include feelings of worthlessness and hopelessness, loss of pleasure in activities, changes in eating or sleeping habits, and thoughts of death or suicide. And then we also look at anxiety disorders. This is a condition marked by excessive worry and feelings of fear, dread, and uneasiness that, according to diagnosis criteria, lasts 6 months or longer. We, of course, if we are seeing it coming in earlier, we want to try and intervene as early as possible. Other symptoms of generalized anxiety include being restless, being tired or irritable, muscle tension, not being able to concentrate or sleep well, shortness of breath, fast heartbeat, sweating, and dizziness. And then your PTSD, or post-traumatic stress disorder, is a class of traumatic stress disorders with symptoms that last more than 1 month. There are various forms of PTSD depending on the time of onset and the duration of these stress symptoms. So we're going to start off with methylation, and I'm sure many of you are very familiar with this pathway. And we do have a separate methylation and inflammation webinar specifically for mood regulation, so please contact us if you would like this one separately. But methylation being proven and shown to be very important in eventual neurotransmitter synthesis and very important in mood regulation, and has been associated quite strongly with your treatment-resistant depressive and bipolar disorders if there is something going wrong in these pathways. So here we are looking at MTHFR as well as MTR, which encodes your methionine synthase, which you can see by the MS. There are obviously you'll notice a number of very important enzymes in this pathway, but from the research, and specifically related, that the strongest research we could find that we could report on for mood regulation is MTHFR and MTR encoding methionine synthase. So those two are the ones that we really seeing variations that are very strong. Of course, the other enzymes need to be supported, because without them, there will still be a problem. With methylation, the MTHFR SNPs that we look at is 677 C to T change and 1298 A to C change, as well as MTR, and this is a 2756 A to G change. MTHFR encodes your methylene tetrahydrofolate reductase, where we see the 677T and the 1298C alleles decreases function of the enzyme and is significantly associated with increased homocysteine levels and risk for depression in an environment of low methyl groups and a low B vitamin intake, specifically folate and methylfolate. And then on the other hand, MTR encodes your methionine synthase, where the G allele is associated with increased risk for depression, especially when vitamin B6 levels are low. And then combining into that methylation, which is very important to consider as a compounding effect, is inflammation. And we see that high homocysteine levels, possibly caused because of genetic variation in methylation, actually exacerbates inflammation. And if this is being exacerbated together with SNPs in these pathways, we do see that increased risk for neuroinflammation and mood regulation disorders. So inflammation has been implicated in the pathogenesis of numerous chronic diseases, including risk for depression and your major depressive disorder. And again, just looking at the SNPs that we mentioned earlier, associated with cognitive decline. And then lastly, going back there, if we're seeing variations in these SNPs, we see increased expression of these genes, and again, increased risk for chronic low-grade inflammation that can manifest as an altered mood regulation and a mood disorder. So the interventions would be the same as what we mentioned earlier in neurodegenerative side. Then in your 1 signaling pathway, this is a new one, your GSK3 beta encoding glycogen synthase kinase 3 beta. The protein is a negative regulator of glucose homeostasis and is involved in energy metabolism, inflammation, ER stress, mitochondrial dysfunction, and apoptotic pathways, so looking at cell death. It has been associated with increased cell signaling and excitatory pathways, and also been associated with bipolar disorder. Your GSK3B is also an important target protein of several mood stabilizers, including lithium. And so we see quite a lot of research going into even low-dose lithium being a factor that can target GSK3 beta, decrease its expression or its activity, and thereby stabilize mood a lot in this area. There are 3 variations that we look at on this gene, and you have to have a combination of all 3 to get the haplotype, which will give you the risk. So all 3 in combination lead to increased expression of GSK3 beta, encouraging cell signaling pathways and cell death. The haplotype of the risk SNPs is associated with major depressive disorder and also earlier age of onset of bipolar disorder. So very important, again, just to consider not as a diagnosis, definitely not diagnosis, but diagnostic insight into individuals who may be seeing mood dysregulation and seeing that there are these risk SNPs coming up. In terms of intervention, we can consider our low-dose lithium if indicated if clinically indicated, as well as an anti-inflammatory diet and omega-3 fatty acids being very important here as well. So inhibition is associated with decreased depression incidence. Enhancing your serotonergic activity or using antidepressants acting on serotonergic systems can also cause inhibition of your GSK3 beta. Moving on to mood regulation and cell signaling, here we look at CACNA1, which belongs to a family of genes that provide instructions for making calcium channels. CACNA1 encodes a subunit of L-type voltage-gated calcium channel, which is involved in excitatory signaling in the brain. These channels, which transport positively charged calcium atoms across cell membranes, play a key role in a cell's ability to generate and transmit electrical signals. CACNA1 variation, the A allele, is associated and has been linked to increased risk for developing bipolar disorder and mood dysregulation or unregulated mood disorders. And so methods to decrease excitatory signaling may be used if clinically indicated, and these include, again, omega-3 fatty acids, anti-inflammatory diet, and where clinically indicated, mood stabilizers. What goes together with the CACNA1 and really should be seen as this compounding effect again is ankyrin 3, encoded by ANK3. This plays a key role in sodium channel functioning and regulation of excitatory signaling, and has also been associated with mood instability. Two variations are tested on this gene. The T and the G alleles respectively increase risk for bipolar disorder and mood dysregulation, and methods to decrease excitatory signaling, just like your ANK3, is looking at that anti-inflammatory diet, omega-3 fatty acids, mood stabilizers, and actually by targeting GSK3 beta, you can get better stability of your CACNA1 and ANK3, and these again may be used if clinically indicated. Moving then on to your serotonin pathway and mood regulation. Here we're looking at 1A HTR1A, encoding your 1A serotonin receptor. Serotonin receptors are critical regulators of the serotonin system. Serotonin receptor HTR1A is a G protein coupled receptor that mediates negative feedback inhibition of serotonergic neurons and signaling in limbic brain regions, including the amygdala. The variation that we look at here is a C to a G change, where the G allele actually blocks transcriptional repression, upregulating your serotonin activity and increasing autoreceptor expression. This is associated with increased negative feedback and reduced serotonin signaling at the postsynaptic sites. So the G allele is associated with MDD and BD, or major depressive disorder, and bipolar disorder. And specifically the GG genotype is where you want to focus if that comes up. This has been associated with completed suicide. Again, how much you want to go into detail with a patient is really very patient specific and must be handled quite sensitively. But it's very important just to understand that the GG genotype is a strong indicator for MDD and BD. And so with these individuals, it gives the practitioner a lot of insight as to trying to improve receptor function. And here we see, so the research suggests that the G allele confers increased stress reactivity and reduced stress coping that may predispose individuals to depression. So the GG genotype, again, only really, it's the genotype is a strong risk factor, but we need those environmental factors, and those environmental factors coming from social stresses and not being able to manage that stress that well. And so in terms of intervention, it's looking at stress management strategies as one of the factors to really focus on to try and improve these individual stress coping techniques. The G allele, which is associated with increased 5-HT1A, your serotonin autoreceptor levels, may also associate with reduced responses to therapies that modify your serotonin system. So it's also considering possible responsiveness to serotonin therapies. In terms of intervention, we know that a significant amount of our serotonin is actually made in the gut, and so ensuring and focusing and targeting gut health is imperative for these individuals. And once that has been corrected, we want to really focus on our tryptophan-rich foods. Exercise will help to improve serotonin. There are some studies also looking at this variation and IBS, because IBS has also been related to a dysregulation with serotonin and serotonin receptors and uptake. And so again, stress management strategies, gut health, really a very big target here, and tryptophan-rich foods, and then more on the medication side, a possible different responsiveness for serotonin therapies. Then moving on to BDNF, encoding a brain-derived neurotrophic factor. We have covered this, so we'll go through it quite quickly here. It is predisposed that this gene may take part in the it is proposed that this gene may take part in the regulation of the stress response and the biology of mood disorders. So again, gene plus environmental factors leading to mood disorders. The T allele is again the risk, where the presence of this MET or T allele results in a 25% reduction in activity-dependent secretion of brain-derived neurotrophic factor, the CNS. Carriers have increased risk for developing depression, and in terms of intervention, one, it's managing those stress-related environmental factors, putting a lot of intervention and focus on stress management strategies, and then also increasing physical activity, as this may attenuate the risk of the SNP, because increased activity helps with BDNF levels. And then lastly, now looking at dopaminergic pathway, the COMT. COMT here, so we spoke about GG genotype being the risk for neurodegenerative disorders. With mood regulation, the VAL homozygotes, so AA genotype, the slower functioning activity enzyme, is associated with risk for anxiety disorders. So to go through it, the VAL homozygotes, AA genotype, have higher COMT enzyme activity compared to the VAL GG have higher COMT enzyme activity. The MET AA homozygotes have a lower enzyme activity. So where we said that the GG genotype was the risk for neurodegenerative disorders because of that fast activity and that fast dopamine breakdown, here we see with the MET or the AA, the slow enzyme activity, we see an increased risk for anxiety disorders because of that slow dopamine breakdown. So fast dopamine breakdown with the fast enzyme associated with neurodegenerative disorders, and slow dopamine breakdown with the slow enzyme AA associated with mood dysregulation and mood disorders. The heterozygotes are not really a problem either way when it comes to these mental health disorders. The role of COMT on dopamine catabolism in the prefrontal cortex provides the basis for its association with cognitive and emotional processes. Across these different genotypes, MET is linked to lowest COMT level of COMT activity and yields the highest level of extracellular dopamine in the prefrontal cortex. MET genotype carriers are associated with panic and anxiety-related disorders, and again, it requires psychosocial stressors, so early aversive life experiences, therefore might increase the vulnerability to anxiety disorders in the presence of homozygosity for the COMT MET allele AA genotype. Decreasing environmental stresses, stress management, avoidance of caffeine and high alcohol intake, which further puts load on this COMT enzyme, and ensuring adequate magnesium intake and nutrients for SAMe synthesis will all be very important in interventions for management of AA carriers who are manifesting anxiety disorders. Then moving on to stress response, your FKBP5. This protein encoded by this gene is a member of the immunophilin protein family, which plays an important role in immunoregulation and basic cellular processes involving protein folding and protein trafficking. This FK506 binding protein 2 acts as a co-chaperone that modulates not only glucocorticoid receptor activity in response to stresses, but also a multitude of other cellular processes in both the brain and the periphery. The gene is regulated via complex interactions among environmental stresses, so again, the variation plus environment, where the T allele is associated with increased risk for PTSD and depression. The SNP provides really interesting diagnostic insight for management of individuals exposed to an environmental stressor. It is also very important in your glucocorticoid pathway, cortisol as well. And so by managing inflammation in these patients, we can also try and manage those cortisol levels. On the other hand, we've got OXTR encoding your oxytocin receptor. This is a peptide hormone and neuropeptide normally produced by the paraventricular nucleus of the hypothalamus and released by the posterior pituitary. It plays a role in social bonding, sexual reproduction in both sexes, and during and after childbirth. So very important, we could almost consider it our loving hormone. Oxytocin has peripheral actions, so these are our hormonal actions, as well as important actions in the brain. The protein encoded by this gene is a G protein coupled receptor, part of the G protein coupled receptor family, and acts as a receptor for oxytocin. Its activity is mediated by G proteins, which activated your phosphatidylinositol calcium second messenger system. And so with the variation, it relates to empathy and stress reactivity in humans, where we see individuals with the GG genotype were better able to discern the emotional state of others than those who were A allele carriers, specifically when in a stressful environment. So GG individuals are more able to manage stress and also are able to relate better to others in stressful situations, whereas A allele carriers may be those individuals who have decreased ability to manage stressful situations, respond negatively to others in with environmental stresses and stressful environments, and don't recognize or have a decreased ability to recognize and to empathize with others in these stressful environments and recognize facial expressions and emotional status of others in these environments. So in these individuals, understanding this possible weakness is very important, both in terms of relating to others, getting stress management techniques into play, and understanding that when they are involved in a stressful environment to actually utilize those stress management techniques. And this has then also been related to post-traumatic stress disorder. So practitioners knowing that someone has undergone a stressor and has the A allele, it's important to put that much more focus on these individuals, knowing that they may not respond to therapy as quickly as someone with the GG genotype. And then lastly, moving on to our addictive behavior. Here we're looking at a very exciting area that is going to be hopefully very useful in your practice, where addiction is a repeated habit pattern that increases the risk of disease and or associated personal and social problems. Addictive behaviors are often experienced subjectively as loss of control. The behavior contrives to occur despite volitional attempts to abstain or moderate use. And what we've seen is that twin studies actually show heritability estimates for developing an addictive disorder, and this ranges from 45 to 79%. So a very strong genetic predisposition to addictive behaviors, not only substance abuse, but also addictive behaviors. And some studies, some researchers almost call this, there's a genetic addiction risk score. And this is very useful and gives a lot of insight to both the patient and the practitioner in dealing with these disorders. In some states, addiction has almost been considered to become a hereditary disease. So addictive behavior can manifest in a number of disorders. All of these behavioral disorders are complex in their etiology and are involved by both genetic and are influenced, by both genetic and environmental factors. Genetics and addictive areas of association that we consider include behavioral disorders, from eating disorders, specifically binge eating, to adrenaline seeking and risk-taking behavior, substance use disorders, risk for alcohol, nicotine, and cannabis, as well as opioid dependence, and then also we look at psychosis response from cannabis use. In the substance use disorders, individual variation in the reward process is associated with personality and temperament, as well as susceptibility to dependence. People use drugs or tend toward addictive behaviors mostly due to the inherent rewarding property, particularly prior to the development of compulsive use. So we can almost consider that these individuals, because of genetic variation and certain environmental factors, have what we could almost say is a reward deficiency syndrome. So substance use disorders continue. The proportion of the drug users who actually develop dependence within 1 year and 10 years after first use ranges quite substantially. So after first use is 1% and 12 to 13% respectively for alcohol, and 1.5 and 8% respectively for marijuana, 5.5 and 15 to 16% respectively for cocaine. So just because an individual has tried it and has tried it once and has used it a few times within their first year does not mean that they're going to become addicted to that substance. And substance abuse, as you can see, it's within 1 year and 10 years after first use. So there's a very broad and a long range where someone can actually become addicted. Individuals with rapid progression from initial use of a substance to compulsive use are more likely to develop dependence. And these are the individuals we want to try and target and actually intervene with as early as possible. Genetic factors that place certain individuals at faster or slower transition are more likely to promote or prevent them to develop dependence. Drug-induced persistent neuroadaptation in reward-related learning and memory processes, which leads to hypersensitivity to drug-associated cues, impulsive decision-making, and abnormal learned behaviors, are the neurobiological basis for the transition to dependence. So to go through that again, your drug-induced persistence, neuroadaptation in reward-related learning and memory processes. So we're going to focus on that reward-related learning and memory processes genes that leads to hypersensitivity to drug-associated cues. So where are those drugs targeting as well? Impulsive decision-making and abnormal learned behaviors. Environmental factors that come through are the neurobiological basis for the transition to dependence. So starting off, I'm going to actually start on one that is not really related to addiction, but from use of a substance can cause a very severe side effect. We're starting off with cell signaling, your AKT1, which is your RAC alpha serine threonine protein kinase. Here we're looking at a C to a T change on the SNP, and we've got the RS number as the identity for the SNP. AKT1 is one of the 3 closely related serine threonine protein kinases called the AKT kinase. AKT kinase is very important in regulating many processes, including metabolism, proliferation, cell survival, growth, and angiogenesis. And what we see is because of the variation that takes place on this AKT gene, it has been very strongly related to risk for psychosis and schizophrenia. So one of the strongest schizophrenia genes that has an environmental impact. If you do not have the environment as with the specific environmental trigger, this gene does not lead to schizophrenia. But if you have the trigger, being cannabis, the possibility and the chances of developing psychosis and schizophrenia is significant. So from one of the studies, we see the odds ratio depending on genotype, and we can see those individuals who have never used cannabis at weekends or less, so just very minimal cannabis use, and then used cannabis every day for a long period of time. And what we see here is carriers of 2 copies of the CC allele of this AKT1 gene were at a significantly greater risk of being diagnosed with a psychotic disorder with long-term cannabis use. And so it's very important that even if individuals are just using cannabis infrequently, but then start to possibly develop a habit for it, and it may be considered safe in many areas, but there are certain individuals, especially if it's the THC that is in there, that leads to risk for psychosis and schizophrenia. So carriers of 2 copies of the C allele, CC genotype, of the AKT1 gene were at a 2-fold greater risk of being diagnosed with a psychotic disorder if they had used cannabis, and significantly increased risk for CC genotype if they have if they've used cannabis on a regular basis for a long term. They have increased risk of paranoia and psychosis with cannabis use. And then I'm just going to speak about the other 2 related to cannabis. Now this is looking more at dependence. The CNR1 gene in the endocannabinoid pathway. CNR1 gene encodes one of 2 cannabinoid receptors. Cannabinoids, principally your delta-9 tetrahydrocannabinol, and synthetic analogs are psychoactive ingredients of marijuana. The cannabinoid receptors are members of the guanine nucleotide binding protein, your G protein coupled receptor family, which inhibits adenylate cyclase activity. Studies suggest that cannabinoids increase dopamine activity in the nucleus accumbens and your prefrontal cortex by activating CB1 receptors in the ventral tegmental area, which increase dopamine neuronal firing and burst rates. So cannabis increased dopamine in a big reward response. CB1 receptors therefore increase dopamine activity by local disinhibitory mechanisms. The gene that encodes for CB1 is your cannabinoid receptor 1, CNR1, thus likely modulates endocannabinoid and dopamine mediated reward signaling. So just something, it's something that maybe I should have mentioned a little bit earlier, but we can actually start to see that different genes and different pathways are related to different choices for substance abuse, different, really not every individual based on having an addiction, an addictive behavior will go for the same substance. There are different substances that actually trigger different pathways, and individuals have their choice drugs or their choice behaviors that really improve the weakness in specific pathways. And that's what we want to target. So the 2 receptors of CNR1 have been found to be involved in the cannabinoid-induced central nervous system effects, including alterations in mood and cognition experienced by users of marijuana. We look at a variation here, T to C change in CNR1, encoding that CBD receptor. Your C allele carriers, the more common allele in fact, had significantly greater activity in reward-related areas of the brain with cannabis use. This is associated with cannabis addiction and mediates neural activity in response to specific cues. And then on the other hand, so again, a compounding effect that we will see, your FAAH encoding your fatty acid amide hydrolase. Your FAAH encodes fatty acid amide hydrolase, and is responsible for the hydrolysis of a number of primary and secondary fatty acid amides, including the neuromodulatory compounds anandamide and amide. Sorry, my pronunciation there, excuse me. And also looking at catabolism of your endocannabinoids. So we make specific cannabinoids ourselves. FAAH is very important in pain, depression, appetite, inflammation, and has been associated with risk of drug and alcohol abuse. FAAH variation has also been associated with disordered eating and higher amounts of food intake. The 385C to A change, so AA carriers produce 50% less FAAH, leading to slower breakdown of anandamide. AA carriers may have a stronger response to anandamide, therefore, affecting the dopamine reward pathway, resulting in happier feelings and less anxious feelings. So AA carriers are at increased risk for problem drug use and dependence because of this extreme reward that they experience from these triggers. So CC genotype carriers show greater activation in widespread areas within the reward circuit as compared with the FAAH A allele carriers. But something just to consider as well with A allele carriers is especially AA genotype, is there may be more difficulty with withdrawal. There may be more difficulty with withdrawal compared to AA individuals with CC individuals. So again, we see AA carriers may have a stronger response and are at increased risk of problem drug use and dependence. So they're the ones that may become more dependent. But it's not to say that CC genotypes cannot become dependent. And so with having the CC genotype compared with their A allele carriers, these CC individuals may have increased withdrawal compared to AA individuals. So it's just important to note who is coming to you for assistance if they are in a rehab facility. Are they AA or CC genotype? AA genotype is probably more of the quicker addictive side because of that extreme reward. We could see increased risk for problem drug use because of the stronger response to anandamide. But the CC genotype, greater activation in widespread areas, and so because of that, a possible difference in the withdrawal compared to AA individuals. So AA carriers produce 50% less FAAH, leading to slower breakdown of anandamide. AA carriers may cause a stronger response, affecting the dopamine reward pathway, and will result in feeling happier and less anxious. Okay, the C homozygotes had a greater activation in widespread areas within the reward circuit, specifically in your OFC and ATG and nucleus accumbens as compared with your A allele carriers. And so just to take note, so A allele carriers, dependence, C allele carriers, the homozygote has got the withdrawal being possibly greater. Then moving on from cannabis addiction to nicotine addiction, which is a severe problem all over the world and is very strongly related to cardiovascular disease as well as cancers and your neurodegenerative disorders. So we want to really try and remove this addiction completely from society. So here we're looking at your ChRNA3 and A5, which encodes your nicotinic acetylcholine receptor alpha-3 and alpha-5 subunits, respectively. We see in this pathway, you can actually see at the top of the slide, at the top of the slide, we see nicotine if we're exposed to nicotine, how it triggers your different receptors and these acetylcholine receptors, which will then go on which will signal your calcium, your sodium channels, leading to depolarization. And then what happens is actually there's an increased secretion of dopamine that occurs. Alternatively, if it's not dopamine, your adrenaline and noradrenaline actually have increased secretion. So depending on where these receptors get triggered, it's either going to be dopamine or your adrenaline and noradrenaline that get triggered. And so that reward that gets increased, or that dopamine that leads to that reward signaling and recognition because of nicotine triggering these acetylcholine receptors. So receptors in the lead, so starting off with ChRNA3, this is the encoded protein, which is a ligand-gated ion channel that likely plays a role in neurotransmission. We could see that from the pathway. The polymorphisms in this gene have been associated with an increased risk of smoking initiation and an increased susceptibility to lung cancer, where the A allele is associated with, on average, a higher number of cigarettes smoked per day and therefore significantly increased risk of lung cancer. The A allele may also predispose to alcohol dependence. So it's not looking at that initiation to become addicted, but if addicted to nicotine, the dependence is so much greater. And so very important for practitioners to be aware that A allele carriers may be at significantly increased risk of lung cancer. So check that DNA damage that is occurring because of the number of cigarettes smoked per day. And so something just to mention as well with the SNP is that, and with the one we're going to speak about as well, is that risk allele carriers may require more than just cognitive behavioral therapy to come off the nicotine. So they actually may require a nicotine patch or another kind of medication to assist with the withdrawal. And then following on to actually assist with staying off the nicotine. Then moving on to the cell signaling ChRNA5, your nicotinic acetylcholine receptor alpha 5 subunit. This protein encoded by this gene is important as it's a member of a superfamily of ligand-gated ion channels that mediate fast signal transmission at synapses. And here we're looking at an amino acid change or a G to an A change, where the A allele is associated with increased pleasure response from the first cigarette, more likely for these individuals to start smoking if they try. On the other hand, just something to note, these individuals may have actually a decreased risk and protection from becoming cocaine addicts. So for those individuals, again, just like with ChRNA3, the difficulty in coming off nicotine is so much greater than without the variant. So more than cognitive behavioral therapy would be required, and longer term assistance for these individuals to actually stop smoking for the long term. Moving on to GABA2, this is your GABAergic pathway. Your gamma-aminobutyric acid receptor subunit alpha 2 is a protein in humans involved and encoded by GABA2. This is the major inhibitory neurotransmitter in the mammalian brain, where it acts at GABA-A receptors, which are ligand-gated chloride channels. Your chloride conductance of these channels can be modulated by agents such as your benzodiazepines that bind to the GABA-A receptor. So very important keeping in mind that those benzodiazepines is a possible risk factor for variant carriers. Diseases associated with GABA2 include alcohol dependence and other substance abuse disorders. Specifically now, if we're focusing on a different kind of substance, it's your alcohol dependence and your benzodiazepines. And why is this? So the CC genotype is associated with alcohol addiction, where the variation on the gene may be attributed to its comorbidity with other externalizing, impulsivity, or internalizing anxiety disorders. The low-risk T allele is associated with better treatment response as well. So again, if you're seeing this and someone is addicted to alcohol or benzodiazepines, the T allele may have better treatment response with specific medications. So again, just to take note, CC genotype, it's because of the underlying factors of externalizing and internalizing behaviors that eventually leads to alcohol dependence. So in certain situations, because of not managing social situations, as an example, not managing those situations very well, having high anxiety, alcohol, just decreasing that anxiety at that acute level, and then those individuals being able to, and then memory formation around situations wherever there are situations of stress, it leads to memory formations that are positive with alcohol, and eventually that becomes an addiction. And then those associations are negative, but the person who is addicted to alcohol doesn't realize that so quickly. So that is the mechanism behind it. It's actually the anxiety, the externalizing impulsivity or internalizing behaviors because of an abnormal receptor for GABA, which is our calming hormone, that leads to this concern. And so a really nice study, and actually coming straight from the conclusion of Trucker et al. Study from 2016, improving prevention programming requires a better understanding of developmental precursors of risk and age-relevant intermediate phenotypes that lead to addiction. Findings offer preliminary evidence that for some youth, genetic risk may be expressed as early difficulties modulating distress. These youth may benefit from interventions that increase stress management and emotion regulation. For other youth, genetic risk may be expressed as early difficulties controlling impulses. These youth may benefit from interventions that increase self-control. So there are your interventions, straight from the study. And then also, obviously, in terms of nutrition, in terms of lifestyle management, trying to manage that GABA pathway, improve GABA production, and we could also look at just providing GABA. Then looking at the serotonergic pathway, a different one here. We're looking at a transporter this time, SRC6A4. This gene encodes an integral membrane protein that transports the neurotransmitter serotonin from synaptic spaces into presynaptic neurons. The encoded protein terminates the action of serotonin and recycles it in a sodium-dependent manner. The protein is a target of psychomotor stimulants such as amphetamines and cocaine, and is a member of the sodium neurotransmitter symphotor family. The serotonin transporter removes serotonin from the synapse, returning it to the presynaptic neuron where it can be degraded or released at a later time. And the A allele affects drinking intensity in alcoholics, possibly by altering serotonin transporter expression levels. AA genotype carriers are likely to be heavier drinkers. For the practitioner to understand AA genotype, heavier alcohol consumption, increased risk actually for comorbidities related to the substance abuse, liver cirrhosis, and other comorbidities, it's going to be stronger with AA genotype carriers. Again, in terms of intervention, intervening as early as possible will really be very beneficial, and also considering your treatment interventions, understanding and getting insight to these individuals having a stronger problem, being heavier drinkers, more severe intervention may be encouraged. And then looking at BDNF, again coming up, the presence of the MET allele, just as a reminder, leads to reduced BDNF in your central nervous system. Your MET or T allele carriers are associated with increased risk for addictive behavior disorders, including binge eating. The polymorphism moderates the association between food restriction and binge eating. So this is one of the areas where BDNF is very important. So the MET allele carriers are more affected by the effect of food restriction on binge eating as compared to BAL or CC genotype carriers. The more extreme the food restriction in T allele carriers, the more prone these individuals were to binge eating. So individuals with the risk variant, they self-restrict, and that's where the binge eating and actually bulimia comes through, bulimia nervosa, so very strong restriction, and then overeating on the other extreme. And then, so that's the one area to look at it. And then in the other area of management, for just general binge eaters and individuals who are overweight, considering these individuals' motivation and restriction, these are the individuals who will rebel more if they are very strongly restricted. So they may require a much more moderate dietary intervention. And so a lot of other things on BDNF, we have a webinar that we are actually creating specifically for this, and especially on the addictive behavior side. And then I want to move on to your addictive behavior, your dopaminergic pathway, where we're looking at DRD1, 2, 3, and 4. Dopamine is your catecholamine neurotransmitter that acts both on the central and the sympathetic branch of the peripheral nervous systems, and is essential in the reward circuitry pathway. Here we can see your dopaminergic pathways and functions being reward and motivation, pleasure and euphoria, your motor function, so important in cognitive functioning, compulsion and perseveration, so perseverance. And then on the other hand, you've got your serotonin, you're looking at mood regulation, memory processing, sleep, and cognition. So we're focusing now on dopamine. And we want a properly functioning dopamine system which controls movement, reward, and pleasurable feelings. Imbalance in this transport system leads to neurological and neuropsychiatric diseases. Starting with DRD1, your D1 subtype of dopamine receptor, the most abundant of the central nervous system. D1 receptors regulate neuronal growth and development, mediate some behavioral responses, and modulate dopamine receptor D2 mediated events. Two SNPs here. The polymorphisms here have been shown to have a dose-response gradient with increased risk for treatment resistance and may be a potential pharmacogenetic marker for antipsychotic drug treatment response. The variants in DRD1 are associated with addictive behavior, specifically risk of opioid, your heroin is very strong, dependence, and pathological gambling. This 4532T allele has shown significant association with alcohol dependence and associated disorders like bipolar and novelty seeking, persistence, and harm avoidance. So both extremes. The TT genotype is associated with increased risk for heavier alcohol use in alcoholism. Individuals, however, with the CC genotype of this SNP have been shown to have an increased susceptibility for nicotine dependence. C allele carriers may also predict decreased post-dependence pleasure in response to opioid use. So it just depends on the genotype and actually the drug of choice. Your DRD2 subtype, D2 subtype of the dopamine receptor, TAC1A, so you'll get an A1 or A2, it's C to a T change. The A1 or the T allele is associated with a reduced number of dopamine binding sites in the brain. We actually look at the SNP both in the MedCheck test as well as in DNA diet because of its association with binge eating disorders. The T allele carriers are associated with increased compulsive and risk-seeking behaviors, increased risk for comorbid substance use disorders, including alcoholism and opioid use, as well as binge eating behavior. And here we can see the D2 subtype of the dopamine receptor, and just looking at how we're seeing the D2 receptor, and actually what happens with the variant is there is decreased receptor expression. So we're getting this dopamine made, and we see then COMT down here. So COMT, obviously, GG genotype, I'll speak about it now, being an important factor if it's working really fast to break down dopamine even further. And then the D2 receptor not being there or being less if you have the variant, and so a reward deficiency developing. The D3 subtype of the dopamine receptor encoded by DRD3 is an important receptor which is localized to the limbic areas of the brain and is associated with cognitive, emotional, and endocrine functions. Here we have a T to a C change, or a serine to a glycine, where the C allele is associated with sensitivity to cocaine, opioids, alcohol, and nicotine dependence. And then lastly, looking at DRD4, your D4 subtype of the dopamine receptor. This is a target for drugs which treat schizophrenia and Parkinson's disease. SNPs in this gene have been associated with various behavioral phenotypes, from autonomic nervous system dysfunction, attention deficit and hyperactivity disorders, and the personality trait of novelty seeking. So the biggest one in terms of behavior is DRD4, where the T allele predisposes to novelty seeking, drug addiction, and ADHD. So on all of these dopamine receptor genes, something we really want to take into account is how can we improve dopamine levels, focusing on that methylation pathway, focusing on the production of dopamine and your neurotransmitters that will assist in mood regulation, especially that dopamine, your good quality protein. There's certain amino acids that we can really put into place. Then understanding that these individuals will have almost that what we consider as this dopamine deficiency, or this reward deficiency syndrome. And so trying to really navigate or improve what type of behavior can we put into place that will help with the dopamine production that will be healthier than a substance abuse or an unhealthy addictive behavior. So good quality protein, avoiding the trigger behavior, the trigger drug, the trigger food, and a lot of psychosocial and cognitive behavioral therapy that comes into play as well. And then in terms of COMT, again, as I mentioned from that image from the dopamine pathway, you could see that the COMT-GG genotype, the VAL-VAL, is linked to highest level of activity, and so the lowest dopamine. And so with the VAL-VAL genotype, this may predispose toward increased risk for opioid dependence. Again, I'm talking, and I've mentioned a few times about this, your genetic risk score. And so looking at 1 + 1 + 1, all of the variations in this dopamine pathway plus COMT being very important to consider the reward deficiency. And then lastly, we look at OPRM1, which encodes your opioid receptor, mu1. This is the principal target of endogenous opioid peptides and opioid analgesic agents such as your beta-endorphin and enkephalins. This is also has important role in your dependence to other drugs of abuse, such as nicotine, cocaine, and alcohol by its modulation of the dopamine system. Here we can see just one mechanism of action for opioids, where at number 1, we can see over here the opioid, and what we see here is when an opioid binds to an opioid receptor in the membrane of a neuron, calcium channels close, blocking positively charged calcium ions from entering the cell, so that the excitatory signaling gets blocked. In addition, your CAMP levels decrease and potassium channels open it, allowing, so that's when the next thing over here, the calcium, then the potassium channels, allowing positive potassium ions to exit the cell. These events hyperpolarize the cell, increasing the charge difference between the cell's interior and extracellular environment and making the neuron less likely to fire an action potential. Quieting neurons along pain pathways with opioids dampens the transmission of pain signals and results in analgesia. If you're considering this to excitatory pathways and someone who's always overly excited, always possibly manic, something that's going to calm them is something that they might go for, because it's going to help just calm those excitatory pathways. So the G allele carriers are associated with increased risk for alcoholism and opioid dependence. The G allele carriers may also have increased pain sensitivity. Compared to the AA genotype, the variant G is also well established in showing more positive treatment response for alcoholism with naltrexone, increasing mesolimbic dopamine release. And so with all of these genes, and especially you can see in the addictive behavior, it's about gaining insight for this individual, for improving prevention, treatment, and targeted healthcare interventions. So thank you very much for joining me today for this overview of DNA Mind. And I hope to be in contact with you soon for any questions that you may have.